Hello again, everybody. Good morning. Welcome to today's Pain Management Echo Clinic. We'll do as we usually do with Echo and start off with introductions. So, hello, I am Troy Jorgensen. I am the Program Manager for Project Echo Nevada.
I'm Paul Snyder. I specialize in addiction treatment and mental health disorders.
My name is Dr. Michael Lewandowski. I am a psychologist. My specialty is pain management. Spent the last 35 years working, helping people with persistent pain. Adjunct faculty, clinical psych department, and associate clinical professor, Department of Psychiatry at UNR. We welcome you.
And our other folks joining us in the room?
Hi, my name is Mervin. I'm an RN at Carson Taro.
I'm Alex. I'm here kind of just to observe. I want to learn more about this.
Excellent, thanks.
Welcome.
All right, and we'll go out to our group starting us virtually. So, Alan, go ahead.
I'm Alan Fisk. I do technical work. If you have some video or audio issues, please let Troy or myself know if we can help you. We will. Thank you.
Thanks, Alan. And our folks at William B. Ryrie Hospital in Ely, who's there joining us this morning?
Sorry, don't know how to run the audio, so.
We can hear you.
Okay, there you go.
So who is that joining us?
Oh, I'm Bob Rosenquist, one of the outhouse doctors here at the clinic.
Excellent, great to have you this morning, Dr. Rosenquist. And then Dr. Bayen, are you there in Ely as well?
No, I'm not. But I'm at the VA actually.
Okay. When did you make that transition?
Well, I'm a double dipping.
Okay. Fair enough. Thanks, Dr. Bayen. Good to have you this morning. And then the next is Josh Unruh. Could you introduce yourself, please?
Can you guys hear me?
Yep, go ahead.
My name is Josh Unruh. I'm a graduate student there at UNR in the acute, working towards the acute care nurse practitioner program, and this is part of our ECHO project that we're doing in our class, so it's good to hear from you guys.
Excellent. Thanks, Josh. Good to have you today. So we'll do as we usually do, and we want to support you with your challenging patient cases, your pain management cases that you're facing out there. So does anybody have anything they'd like to discuss and review with the team this morning? It's open to anybody. Dr. Rosenquist, Dr. Bayen, Josh. Any difficult things you've seen in the last week or two?
Not at this point in time, thank you.
We'll move on to the presentation from Paul for today. But feel free to chime back in with any questions or comments if you have any. Take it away, Paul.
Okie dokie. Well, today we're talking about opioid solutions, strategies for pain patients. So this is perfect with what we were just talking about. So we'll cover Naloxone, Good Samaritan Act, MAT and PMP and a bunch of other stuff. And what's interesting is October 16th, 2019. You know, I frequently go back about a decade, about 10 years, and think, what would I be talking about in 10 years? And this is what we're talking about. So it's interesting to think 10 years from now, what are we going to be talking about? What are we working on now that's going to come up? Oh, we already took care of that. So Opiodphelia, Opioidphobia. I think what's important is with opioids, they're neither good nor bad. People with dependence are neither good nor bad. We're not making a chemical good or bad. A chemical is what it is. It's like a rock. If you take a rock, it's not good or bad. You can use that rock to build a house, good. Or you could use that rock to throw at somebody, bad. So when we're looking at the opioids, when we're looking at people, we're not looking at making a bad person good or a bad chemical good. We're looking at it as a tool to help us. So a history of opioids, we've had a love-hate relationship with opioids. War on pain, so this was our effort to But what it ended up being was an effort to create an epidemic. And to do that, we need a lot of cooperation from drug manufacturing to liberalization of the DEA, FDA, licensure boards, legislature, approving OxyContin, right to pain relief act by legislation. We needed poor science. It's Portnoy, who had 38 people in his study group, and then we needed physician and promotion of literature considered as peer-reviewed literature. So we needed all of this stuff coming on because somebody had the idea that pain was not acceptable. And so everybody jumped on board with this. That's why we have the smiley faces in all the hospitals. Everybody has to leave with a happy face. They can't have that frowny face. So I'm walking, I was in Tennessee, and I go into a craft fair, and I see this sign, and I thought, is this snake oil, or is this the real deal? They're gonna give soothing and safe relief for arthritis, bursitis, backaches, neck aches, joint pain, muscular pain, fibromyalgia. It's everything and more. Stress and tension. Here's our anxiety, earaches, cramps, swelling. This is a miracle cure. What is it? So it's a cherry pit pack. And it will take care of all this stuff. It's soothing and safe relief. No fragrance added, so it's pure. It's odor-free. Here's the problem. When we start off and launch into a road like this, then we invite things like this. I don't know if these people are medical professionals. However, they're in the medical game. And I'm calling it a game because it's say whatever you want because you don't have a license to protect. If you look up any of your questions on substances that are being promoted right now, you're gonna probably get an ad from Google telling you all of the good things that are going on. So innocent until proven guilty. So let's review. Remember DDT? Lead paint? Roundup's relatively new. How about asbestos? Cigarettes were all the rage. They were great. Does anybody remember Bextra? I don't have that up there.
Yeah.
That was about 2005. I was
Vioxx
and Vioxx. Yep. How about vaping? Yeah, vaping's happening right now. So I was launching Crestor, and we were going up against Pfizer's Lipitor, and I was talking to a cardiologist. He said, look, you know, I showed him our studies. We had a 10,000 person study, and that's a big deal to go through and get all the numbers that you need and then be able to present it. And he kind of put it into perspective when he said, how many reps do you have? And we had about 6,000 reps at that time throughout the world. And he said, I'll tell you what, this study, okay, it's showing some promise, but you let loose 6,000 reps throughout the world, and you let them go for a year. And then we're going to be able to find out really what's going on with your drug. And I thought, you know, that's the kind of doctor that I want. I don't want to be experimented with any like products. I want them to be tried and true. So when we're going back now, so we're focusing on opioids. So as an addiction specialist, I'm going to bring in some addiction stuff. 4 out of 5 new heroin users started out misusing prescription painkillers. 94% of the respondents in a 2014 survey said they chose heroin over opioids. One, because heroin is twice as potent, twice as strong as opioids, but opioid out on the street for an oxy, it costs about $1 a milligram. So an 80 will cost you 80 bucks. People that I see are on 3 or 4 of these a day, whereas you can get a baggie of heroin for 10 to 15 bucks. The difference is Well, with all of these opioids, they have a relatively short half-life. So that means that every 6 hours or so, they're starting to get into their withdrawal symptoms. And a lot of times, they're avoiding the withdrawal as opposed to going for the euphoria. When they're seeing me, they're not really having fun. They're trying to avoid that withdrawal.
I got an interesting fact. $1 a milligram. In Mexico, it's only 25 cents a milligram.
Really?
I was there last week for fall break, and I walked in a pharmacy, and all the signs of all the drugs that they can sell. And I saw one oxycodone, and so I just started talking to the lady. She's like, "Oh, I can sell you Oxy 80s, 10 of them for I think it was 800 pesos, which is $150 American."
Really?
Yeah, so 10 pills in Mexico at Oxy 80s will drop it. You drop $150.
Wow.
Think about, and then, well, just think about that market.
Crazy, right?
Wow.
But then also, if you notice, I got my hair cut. So I'm talking to the hairstylist and or cutter, whatever you want to describe them. And she said that her sister-in-law was just buried that day. Sparks person, lives in the neighborhood. She was on opioids and benzos. She had overdosed, it was 3 times in the last 4 months. And
why do they continue to prescribe?
There was no prescribing. She was having it delivered from a runner because you can get them online. And when they looked under her mattress, between her mattress and her box spring, they had 200 bottles of opioids and benzos.
Wow.
Just all kinds of stuff. Here's the problem. There's a lot of fentanyl out there too. And so with all of the street drugs, you don't know what you're getting. You don't know the potency, purity, consistency. It's not FDA regulated. You don't have directions for use. You don't send it into your insurance company. You're getting what's out on the street. And so if they're lacing it with fentanyl, many times the mindset is for somebody who's in the dependence world, if they find out that fentanyl is the good stuff and it's being used, they're not afraid of it. They're thinking, that's the good stuff. I want the good stuff. Now, if you tell them that somebody has overdosed from it, then they think, well, I'm going to carry my naloxone, and you know what? They don't know how to handle it. I know how to handle it. When you're getting into fentanyl and carfentanil, which is 1,000 times more powerful than morphine, 2 grains of, let's say, the size of salt, 2 grains of salt or 2 grains of sugar is enough to overdose anybody at this table, anybody in this room. So that's the stuff that's coming in. So when we're looking at opioids, there's all kinds of different opioids. We'll look at the 3 major types. There's the natural ones, that's morphine and codeine. You have semi-synthetic, that's your hydrocodone, oxycodone, heroin. And then you have your fully synthetic, that's your fentanyl, methadone, and tramadol. So what does an opioid do? It activates the mu receptor. And so it not only covers up the pain, but it also gives a sense of euphoria or reward. Potential problems, overdose. Here's one of the big problems when you're looking at brain injury as little as 4 minutes without oxygen, because it's not that the body doesn't want to breathe, it's that the body forgets to breathe. So if you cut off somebody's oxygen supply for 4 minutes, and you do this consistently, or maybe it's 5, or maybe it's 6 before they're revived, response times are really fast with our emergency responders, but 4 minutes is a really tall order. How many people who have been overdosed actually have some brain injury? And the longer they go without oxygen, the more severe that brain injury can be. Long-term changes in the brain impacts your decision-making and behavior regulation, addiction, physical dependence, tolerance, withdrawal, opioid-induced hyperalgesia, that's what we were talking about a little bit earlier, where it's actually a worsening of the pain despite the aggressive opioid therapy because the person is actually more sensitized now. And then you have constipation, all kinds of deficiencies, infection risks with injection use. Here's the thing, when somebody's going through withdrawal, everything that's been constipated or tightened up is now released. And so everything is flowing where it used to be the other way around. This is our reward circuit. So when we do something pleasurable, the ventral tegmental area, VTA, nudges the nucleus accumbens and says, hey, this is pleasurable. What we're going to do is we're going to say, hey, prefrontal cortex, this is a good activity for our survival. So we're going to give you a little bit of dopamine in response to whatever the activity is. So playing basketball, hanging out with friends, watching a movie, you get a little bit of a dopamine release. When the opioids are flooded through this system, a couple of things happen. The brain adjusts to the surges of dopamine by producing less dopamine or by reducing the number of dopamine receptors, which means that you need more. Here's the problem with addiction. When somebody has this kind of dopamine release and it doesn't take any effort, because it doesn't take any effort to take a pill or to smoke something or to inject anything, now they compare that feeling with playing basketball or going to a movie or hanging out with friends. And so they've changed their baseline, and now if they're comparing it, then the easy dopamine release will generally win out. Here's an example of effects of drugs on dopamine release. So say you're playing basketball or you're eating food. Food's always a good one. So we're cruising around right now. If you're feeling pretty good, you're probably around 100. You're doing well. You got out of bed and you're going to work. You're doing your thing. You have food. You have a little bit of a spike, maybe 50. So it goes from 100 to 150. Now the hippocampus remembers this dopamine release and says, wow, that was good for me. I'm going to do this again. Your bar is low. You're into a real healthy dopamine kind of release. With amphetamines, this is methamphetamines, it goes up to 1100. So if you're dumping all of that dopamine, now you're chasing what they call chasing the dragon. You're always trying to get back up to that and you're comparing it. That's why people on meth will stay up for, the average bender is around 3 days. Cocaine is around 350. Nicotine, you get that short burst, but look at that, it goes right back down. So you get that short burst, hits the lungs, hits the brain, you get that dopamine release around 2.25, boom, down. Morphine, nice, slow and steady, that's your 200. To put it into comparison, sex is around 2.25. That's the highest dopamine release that we can achieve internally. That's for procreation, keeps the species going. Then, just like we were talking about before, all these brain regions are important in drug abuse and addiction, and all of these brain regions need to be addressed when you're going out of that forest or trying to get the person back into a healthy lifestyle. So memory and learning, motivation and drive, inhibitory control, and reward salience. Now, the prefrontal cortex begins to mature around the age of 25. So if the person is an adolescent or younger person and we take that prefrontal cortex out of the equation because it's under development, then the impact is even longer and more powerful and harder to rewind. So when we're looking at the young people out there, anybody younger than 25, we have to step in the role as their surrogate prefrontal cortex. And if we see them going down a bad path, say, this is not a good path for you. So here we are. Let's talk about naloxone. Good Samaritan Drug Overdose Act. Naloxone's been used in hospitals for years. It works in about 2 to 3 minutes. The problem with naloxone is it lasts for about 20 minutes. So if somebody's in an overdose situation and you give them 1 shot of naloxone, the opioids can reattach to those mu receptors. So you better have a couple of shots available so that if the trip's going to take a little bit more than 20 minutes, you want to make sure that you can help that person out. Another thing is many people, after they've been impacted with naloxone, come up agitated. They've worked as hard as they could to get that drug into their system. They're in a euphoric, nice, peaceful, sleepy kind of nodding off mode that they've spent a lot of motivation or a lot of energy to get to, and somebody just threw a big bucket of cold ice water on them. So they're not going to be too happy. So that's a little cartoon showing how the naloxone works. It knocks off that opioid. If you put naloxone in, again, you're going to probably get them started into an active withdrawal right then. Anyone can administer it. The idea is you don't want to penalize somebody to call 911 or emergency response if they're with somebody who overdoses. So there's your naloxone. You can get it in standing order, Walgreens, CVS. So no prosecution for simple possession and use. Now, that's just kind of a blanket statement. If you have CPS involved, this is a CPS situation, then there's going to be some repercussions. You see the kid in the back, and the parents are conked out there. So medication-assisted treatment. So we have our methadone, buprenorphine, and naltrexone, not to be confused with naloxone. Naltrexone's Vivitrol generally. And like we were talking about before, this is in combination with counseling and behavioral therapies. It's not just the substance, it's getting the counseling and behavioral therapy as a team approach. So methadone, Schedule 2, full agonist to the mu receptor. There's possible overdose, continuous dosing, and successful outcomes studies. So it is beneficial. There's 2 different types of strategies when somebody is on methadone. One is to continue them on methadone, and you ask, what's your exit strategy? And it's, what exit strategy? It can go on for years. Another one is we're going to get them in on methadone, then we'll take them to buprenorphine or Suboxone, and then maybe go into naltrexone, but we want to titrate them off of the substances. One of the harm reduction philosophies is if you are providing them with methadone, which has a really long half-life, then the person is not going to be robbing places or homeless or injecting themselves with dirty needles, and this way we can control it. Buprenorphine, Schedule 3, it's a partial agonist, partial antagonist. Both methadone and buprenorphine have street value. Back to buprenorphine. Partial agonist and partial antagonist to the mu receptor. Naltrexone, no street value. Guess what? It doesn't have any euphoric feelings at all. Actually, it blocks the mu receptors. Now, there's 2 different types. There's the immediate release and there's the 28-day injectable. the 28-day injectable is the one that has the best outcomes. Because if somebody wants to use, they just don't take the immediate release that lasts for 24 hours. They'll, with the injection, it's a deep muscle injection, and it covers them for completely 28 days. So there's no option of turning that one off. Here's another cartoon showing how methadone covers the opioid receptor, buprenorphine about half and half, and then naltrexone blocks it. So benefit, helpful in withdrawal because they have the mu receptors covered, helpful in reducing cravings, reduces the euphoria of subsequent opioid use because those receptors are already filled, in efficacy in opioid use disorder. It's also cost effective. Many times, if you look at if you're going to send somebody to a methadone clinic, know the methadone clinic. There's different philosophies for different methadone clinics. Some say you can use methamphetamine, you can use cannabis, you can use whatever you like to use, just not benzos or alcohol, because that's a deadly mixture. Some say, no, you can't use anything. We're going to be doing methadone as well as the counseling to help you move forward. There is an overdose risk. There's misuse risks. It does have street value. Everything that you get with the opioids, dependence and addiction. Buprenorphine, certification is required. It's a pretty easy certification class. Actually, I'm not a physician. However, I took the certification class just because I was interested in it, and it was a Saturday. It's 8 hours, and they certified me. So they made a mistake. I'm not certified. Okay, so benefits, good for withdrawal management. You can titrate up or titrate down, depending on the healthcare provider's philosophy. You have daily oral or long-acting implants, and there's dosing guidelines. You need a waiver to prescribe buprenorphine in outpatient settings, and they limit the amount of people that you can see the first year and the second year, and there's a recent increase to 275 patients. Now, what's interesting is that you can write opioids with both hands. Yeah. But
No training.
No training. Yeah, well, you got that medical school thing. Well, it depends on where you're getting it, what pharmacy you're getting it from. If you're in Mexico.
Yeah. But training in medical school is very limited.
That's to consider. Also, there's a risk of you're inviting the DEA into your office. So there are limitations. It's effective for withdrawal help. Oh, one of the things with methadone, a lot of times they want the person in active withdrawal before they get them on methadone so that they feel that relief, and then they chances are they'll be coming back. Back to buprenorphine, there's potential dependence and addiction. It's an opioid agonist. Naltrexone prevents opioid intoxication. Also good with alcohol use, and it has no addiction or dependence potential. Here's a picture of Vivitrol. Limitations requires completed withdrawal from opioids. If you put naltrexone in, it's clearing up those opioid receptors. It has a high affinity to attachment, and so it will blast off those opioids. So you'll probably send the person right into withdrawal. Counseling does not have to be voluntary to be effective. A lot of times I like it when somebody has some skin in the game. Either they have something to lose. If they have nothing to lose, then really, where's the motivation? Because that remorseful time sometimes is is very limited. And so I need them to be involved in their treatment. We focus on treating the whole person. That's why ECHO is fantastic. It brings over a whole team so that we can address every part of the person. Treatment plans change as the individuals progress, and individuals have individual treatment plans. So not all treatment plans are considered this, or people are considered the same, nor are their treatment plans. Example is AA. Sometimes AA is the whole treatment, sometimes it's none, sometimes it's really good, and it wanes after treatment. And it's an essential component of MAT. We're running time, folks.
Yeah.
So, Troy, take us home.
All right, thanks, Paul. So yeah, we will be back in 2 weeks. It'll be November 6th will be that session at 8 a.m. Our plan is to have you present your cases, so please bring your cases. We'll also wrap up this talk from Paul as well, since that'll take us a little bit of time to do. So, but yeah, if you have any cases, please bring those next time. And I'm going to share a little quick post survey that we'd like you to complete as well. But in the meantime, please feel free to reach out to me if you have any questions or anything that comes up. Thanks, everyone. Hope to see you next time.
Thank you.
Boom.